Good morning, everybody. I have 10 o'clock, so we're going to get started, and hopefully more people will join in as we get going here. And so thank you for joining us today. My name is Laura Vanderhill. I'm a quality improvement specialist here at Health-Centric Advisors. And today we're going to be talking about prevention and management of patients with chronic conditions, specifically around heart health. We're going to be looking at hypertension and cardiac rehab, and we're really thrilled to have a guest speaker today from Million Hearts. Next slide, please. So for those of you who may not be familiar, so the IPRO QIN-QIO, we together, IPRO Health-Centric Advisors and Clarent cover 11 states plus DC in the Northeast region. And we work to help ensure high quality and safe healthcare for about 20% of the nation's Medicare fee-for-service beneficiaries. Next slide, please. So we are recording today's session. We'll have the recording and slides on our website later, and we'll be following up with you with more information about that. We do ask that you keep yourself on mute today during the presentation, but we really want to make sure that people are active in chat. So please, ask questions, introduce yourself, let us know what you're doing around heart health. And also during the presentation, we do ask that you use the reactions tab, so you can find chat and the reactions tab in the black bar at the bottom, though I'm sure most of you know how to use Zoom by now. All right, next slide, please. So this is our kickoff session for our new chronic disease learning series. We definitely going to have a prevention and management focus. We're going to be looking at heart health today, and then chronic kidney disease in March, and diabetes in April. We're also going to be talking about cardiac rehab again in May, sort of taking a deeper dive. And we're going to be looking at the role of nutrition. And we're going to be looking at health equity throughout. So we're going to be talking about disparities and then ways to address those disparities. Next slide, please. So learning objectives for today. We're going to be hearing from Haley Stolp from the CDC, Million Hearts. So she's going to talk about the hypertension and cardiac rehab tools that they have. And then we're also going to circle back at the end and just touch on some health disparities and some tools and strategies for addressing those. So without further ado, I'm going to introduce our speaker. So Haley is here today, and she's a health scientist, like I said, at the CDC. She is very active in the Million Hearts Cardiac Rehab Collaborative, and she is going to be talking to us about everything that's going on over there. And Haley, welcome, and it's all you.
Thank you, Laura. I'm happy to be with you all. Good morning. Quick disclaimer, the comments are those of my own, do not necessarily reflect that of the CDC. Before I jump right into the data, I always like to bring home the burden of cardiovascular disease. So if you would, go to the reactions tab and pull up the heart if you know someone that's had a heart attack or stroke. And you can look at the gallery screen and see hearts from colleagues and see a lot of them popping up. All right. Oh. And keep the heart up if you know someone that's died from a heart attack or stroke. So for me, that was my grandfather died at the age of 70, which is my dad's current age. So when we think of the years lost due to cardiovascular disease, it's pretty profound impact across the country. I'm seeing a green line across the screen. I don't know if there's a way to delete that or if anyone else is seeing it. No.
I see it.
Okay. I'll continue on, but if there's a way to delete that green line, that would be helpful. So these are provisional data from 2021. And yes, heart disease was the leading cause of death. COVID is no longer the third leading cause of death, but it was at last year in 2021. And we know that there's been over 1.5 million people that have had a heart attack or stroke, and 800,000 die from cardiovascular disease every year. So it does remain the leading cause of death, despite what we see in the news. Heart disease doesn't always get the attention that we'd like it to have. Looking at a graph, this is by colleagues from David Goff and colleagues, they looked at mortality rates through 2018 and calculated the annual percentage change from year to year. And over time, they noticed the inflection point in 2011 where the slopes of the lines changed. So at 2011, we see that decline in the slope flatten out. And now we see for stroke in red, it's pretty much flat. And in fact, a clean increase in the incline for heart disease. And we attribute that largely to the rise in heart failure. But the troubling trend is concerning, seeing that heart disease is now having an increase in mortality for some populations. So our work is focused on helping to steepen that decline and continue our advancement in preventing cardiovascular disease. What's even more troubling is the change in heart disease mortality we see among younger folks. So these are data from looking at ages 35 to 64 years of age from 2010 to 2017. And we see that in the heart disease death rates are on the rise in the population in 70% of all counties in the country. And this doesn't necessarily see around the stroke belt. We see it from California all the way through Maine. So the dark red indicates an increase in heart disease mortality for this lower age population. These are very concerning trends and just, again, emphasize the need of our focus on cardiovascular disease and what's happening in the younger populations.
Haley, can I just stop you for a quick second? Would you be able to maybe stop your screen share and then restart and see if that line disappears? We weren't able to remove it from our end. My apologies.
Yeah, let's see. Oh, that might have been it. There we go. Thank you.
Thank you.
Perfect. Thanks, Haley.
So what can we do about preventing cardiovascular disease? Well, we did a lot of modeling a few years back, and we found that blood pressure control can get us our biggest climb towards our mark for 1 million hearts is 1 million cardiovascular events avoided. So blood pressure will give us almost 600,000 if we reach our target of 80% blood pressure control. And we look across the board, the other impact, second, cholesterol management. Cardiac rehab did not fit into the modeling platform, but we know that cardiac rehab can help prevent secondary events. So overall, what we're talking about today is blood pressure control and cardiac rehab. And to help achieve that goal for blood pressure control and all across the ABCs of aspirin, blood pressure control, cholesterol, and smoking cessation, we developed the Million Hearts Initiative. So currently, Million Hearts 2027 has the goal of preventing 1 million heart attacks and strokes by 2027. We have a focus on 3 priority areas of building healthy communities. This is what we think of more as our traditional public health activities, optimizing care in partnership with clinical partners, and then focusing on health equity across the board. And today, again, we're talking about blood pressure control, the target of 80% blood pressure control across the country. And for increasing cardiac rehab, we hope to help at least 70% of individuals that are eligible for cardiac rehab to participate in at least 1 session. So pretty low threshold, but that 70% target can be pretty monumental in preventing about 125,000 events and saving 25,000 lives. I'm sorry, 180,000 events and saving 25,000 lives every year for that 70% target on cardiac rehab. And then finally, for focusing on health equity, we see our focus on clinical policies, processes, and practices, clinical and public health, to help improve outcomes for these 5 priority populations, for which we see a disproportionate burden of cardiovascular disease and an opportunity to help build equity among these groups. So diving a little deeper into optimizing care, improving blood pressure control, and increasing use of cardiac rehab. We've got them all listed out here with the acronyms, but the key points in bold here is really all of the interventions we have emphasized for improving blood pressure control are included in what we call the Hypertension Control Change Package. And for cardiac rehab, it's in the Cardiac Rehab Change Package. If you could use the reactions to give a thumbs up if you've heard of either of these tools, the Hypertension Control Change Package or the Cardiac Rehab Change Package. Awesome, I'm seeing a couple of thumbs pop up. Well, if you haven't, we're going to dive into them in today's presentation. So then looking at focus on health equity, these are the strategies across our 5 priority populations. And you'll see a lot of the strategies included in the Hypertension Control Change Package and the Cardiac Rehab Change Package are spread throughout. But overall, we have a focus on some key interventions such as self-measured blood pressure monitoring, medication therapy management, and is MTM. And we're also leaning into expanding coverage in these areas as well as a means of building equity. So we'll start with hypertension. So the burden of hypertension is pretty profound. We've got a hypertension problem in this country, if you're not aware. There's over 100 million people with hypertension. And it ranges by age as well as race and ethnicity, 53% among non-Hispanic Blacks in our country. Of the 87 million recommended to be on medications, we know that 71% are uncontrolled. That's about 61 million adults. So we only have a control rate of about 25% in this country. We've got a long ways to go. And cardiovascular disease is not the only problem caused by hypertension. As many of us know, uncontrolled hypertension can lead to cognitive decline, kidney disease or failure, sexual dysfunction, peripheral artery disease, pregnancy-related complications, and vision loss. So while we're talking about cardiovascular disease today, it's really a wide spectrum of problems caused by uncontrolled hypertension. And a lot of times we think it's because people are out of care that they're having problems with hypertension. Well, that's not the case. Among people with hypertension, we know about 91% have a usual healthcare provider, and 93% of those have had a visit in the last year. So these people are in care, and yet their hypertension is not being controlled. And we know we could do better. And it has been done. So these are the list of our 2022 hypertension control champions. These names were just announced yesterday. All of these champions achieved an 80% or better blood pressure control in the year of 2021. So they're the 2022 champions. So we take a moment to applaud. You see there's a couple in New York. We have one in Delaware. And a couple others across the country that we're really helping to emphasize. And this is during the pandemic as well. So a lot of applause and recognition is needed. Over the years since 2012, we've recognized 143 champions that have achieved either 70%, but now it's 80% blood pressure control as part of this recognition. And we're happy to add these 9 new champions to the list. And we've worked with these champions over the years to find out what works and gathered all of those lessons learned, as well as looking through the published literature and speaking with other exemplars across the country to gather what works. And thankfully, we know what works, and we put it into the Hypertension Control Change Package. This is a tool that was just recently revised as a second edition in 2020. It includes a number of evidence and practice-based strategies for changing a given care process. And we've taken the change package even further by including tools and resources to help facilitate the implementation of the change ideas. So if you're not familiar with the change package, this is a concept from the Institute of Healthcare Improvement, and it's broken down into what we call the focus areas. And for the hypertension control change package, it starts with key foundations. This is where you can find content on treatment protocols, office redesign, equipping care teams, focusing on accurate blood pressure techniques and establishing self-measured blood pressure monitoring programs, a population health management component that can help you identify undiagnosed hypertension and or people with chronic kidney disease, and using data to drive improvement, and then individual supports. And these have a wide variety of patient supports for lifestyle modification and using order sets. And each of these different focus areas is broken down into change concepts. These are large notions of change. And then under the change concepts are the specific actions. These are the change ideas. These are the really specific strategies that can be taken. And then we take it a step further again by having those tools and resources that can be adapted or adopted in the healthcare setting. And these are all been tested and proven to work in other practices across the country. So just to walk you through what this looks like, if we were to start with, say a health system decides wants to use data to improve their hypertension control, and they want to specifically look at quantitative data. So for quantitative data, there's 2 change ideas: determining hypertension control and relaying process metrics for the practice, and regularly providing a dashboard of blood pressure controls, metrics, and performance. And say this health system wants to start and explore what a dashboard could look like to help use those data. Well, we have a whole spectrum of different dashboards used and tested and shown to be effective in improving blood pressure control. There's graphs, there's pie charts, there's a whole bunch of different visual tools and different types of dashboards that have been used. And for your use, your interpretation, all of it is publicly available and for you to use or steal or adapt as you feel needed for a health system. Going back to those key tenets for hypertension control, these are the types of processes, policies that you'll see throughout the change package. Of course, we start with the accurate blood pressure measurement, the use of treatment protocols, any protocol, just make sure you have a protocol. We use protocols all the time for standardizing care. Team-based care, and we're learning all new ways of how to incorporate pharmacists and nurses and community health workers. And we have a new project right now where we're exploring how to use medication therapy management in the community setting, adopting Dr. Ron Victor's model and bringing pharmacists into the community, into barbershops, salons, faith-based organizations. So figuring out how that works has been a really exciting project. Medication adherence strategies, of course. I mentioned SMBP. Medication intensification workflows. We put a lot of new attention into this area. We're seeing a lot of patients across the board are on monotherapy when they really should be on a fixed dose combination therapy to improve their hypertension control. So there's been a new focus, and then might see some new measures to look at fixed dose combination therapy versus monotherapy. Other patient engagement tools, and for this, there's actually our next learning lab is going to be focused on patient engagement tools for bidirectional referral, and then use of data to improve outcomes. A couple other resources from Million Hearts. So all of our efforts around blood pressure control, I mentioned undiagnosed hypertension, our SMBP webpage, as well as a new webpage on hypertensive disorders of pregnancy is all available on our blood pressure control webpage. The Learning Lab is a training opportunity. We partnered with the National Association of Community Health Centers, and this is AMA accredited learning. So clinicians can get credits for participating in this session. And we'll have the link in the chat just for a moment for you all to explore. If you're not part of the Learning Lab, it's an opportunity for clinicians to get those credits, but also to engage with specialists across the country. Our Million Hearts SMBP forum meets on a quarterly basis to help emphasize and cultivate widespread use of SMBP in collaboration with payers, purchasers, Medicaid agencies. We have a very multidisciplinary approach to SMBP. And then finally, our NAC Million Hearts Initiative webpage. And this is where you can find materials on our past work with NAC. That's the National Association of Community Health Centers on hypertension management, but also cholesterol management as well. So that's our hypertension. We're going to take a break and move into cardiac rehab, or cardiac rehabilitation, if you will. So I don't know if everyone's familiar with cardiac rehab, but just a quick overview. It's a comprehensive, medically supervised secondary prevention program, typically administered over 36 sessions, over 12 weeks. And it's really intended to help a patient recover from a cardiovascular event and set them on a new trajectory of health. That's it in a bucket. But you do see the core components of cardiac rehab extend beyond what we think of as traditional secondary prevention to include tobacco cessation, a psychosocial management component. You get nutritional counseling, diabetes management. It's very comprehensive in addressing the different risk factors for cardiovascular events. It's a program typically administered in an outpatient hospital setting, and it's provided by a multidisciplinary team. So it really is a team-based packaged deal, if you will. You've got access to a supervising clinician, exercise physiologist, pharmacist to help manage medications, again, nutrition and dietitians and psychosocial counselors. There's also a peer support in cardiac rehab that can be really instrumental for folks that are a bit nervous after having a heart attack or a different cardiovascular event. Having that kind of social support and addressing some issues of social isolation can be another benefit of cardiac rehab. Now, unfortunately, it's not available to everybody. You have to have had a heart attack, have stable angina, received a stent or angioplasty, or have a special type of heart failure, and or undergone bypass valve or heart-lung transplant surgery. So if you have had one of these events and you survive, you've got access to this program. Now, unfortunately, participation is not what we'd like to see. This is data looking at qualifying events in 2017 among Medicare Part B fee-for-service beneficiaries, and only about 29% of all patients will participate in at least one session. And again, our target is 70%, so we've got a good amount of ways to go. Of those that participated, we see that 23% attended up to 12 sessions. I'm sorry, this is the global. So of all those that are eligible, 23% participated up to 12 sessions. And we know that 25 sessions or more is what we consider a clinical threshold for cardiac rehab benefits. So not quite there. And then 8%, only 8% of all eligible Medicare beneficiaries are completing a cardiac rehab program. And then looking at disparities, these are persistent disparities and by sex, with the number of men versus women who initiate cardiac rehab is 3-2, and the enrollment rate's much higher among non-Hispanic white populations versus the non-Hispanic Black population. And while we see 29% as being the overall enrollment across the board, I've got the different states listed out for their average Medicare participation. And in yellow, you see the health-centric advisors states, in purple is the IPRO states, and in blue is the qualified states. So quite a bit of spectrum. It has a wide range from Nebraska, about 56%, down to Hawaii, which I think is about 9%. Can't quite see the end of that tail. Yeah, 9.4%. So just a general idea of where the states lie across the country for Medicare participation in cardiac rehab. Now we do have another change package to help folks address disparities and increase uptake in cardiac rehab. This tool was developed in collaboration with our partners at the American Association of Cardiovascular and Pulmonary Rehab, AACVPR. This is the trade group, if you will, for cardiac rehab programs. And again, we list all the process improvements with the implementation and resources. There's about 105 tools, and we've partnered with 36 cardiac rehab professionals and researchers to help populate the content of the change package. And this change package is broken down into 4 focus areas as well, starting with systems change, where you can make cardiac rehab a priority for the health system. Referrals, and that's about incorporating referral into the processes and standardizing that referral process. And again, of course, using data to improve those processes for referral. Enrollment and participation speaks largely to the use of having a cardiac rehab liaison, inpatient, and/or a care coordinator to facilitate enrollment in cardiac rehab. There's also some strategies to help address some of the disparities we see attributed to cost sharing, access to a program, time constraints. So we've got a couple of different models available for optimizing participation for patients that have those barriers. And then finally, adherence, and that's identifying patients at high risk for low engagement, and then improving patient engagement with some different approaches. So those are the 4 buckets of the change package, but I'm very happy to share that we are in the process of revising it. So there'll be a second edition of the change package released later this spring, potentially June. We're very excited to be sharing this new version. It has twice as many tools, so we're looking at almost 200 tools. And it'll include some content helping build the business case for cardiac rehab, supply some opportunities for staffing models to incorporate interns and/or keeping exercise physiologists, more tools for implementing automatic referral with care coordination. This was tools gathered from our partners at AHRQ and the Take Heart Initiative, building strategies to build equity in cardiac rehab enrollment. So a variety of other tools on how to address barriers such as transportation to programs. New tools for hybrid cardiac rehab programs. These are models that include a outpatient, home-based cardiac rehab and an in-person cardiac rehab. So some element of virtual cardiac rehab, still with that synchronous audiovisual, and as needed an asynchronous component, but overall extending the reach for cardiac rehab beyond the walls of a brick and mortar facility. And then finally, some strategies to increase cardiac rehab participation among heart failure patients. So unfortunately, patients with heart failure have the lowest participation rate across the board by qualifier. I think only about 3% of Medicare beneficiaries with heart failure are participating in cardiac rehab. Just some other aspects of cardiac rehab that Million Hearts contributes to beyond the change package. We establish and nurture partnerships with our Million Hearts Cardiac Rehab Collaborative. If you're not familiar with it, we are a multidisciplinary open forum of people all committed to that 7% target. Their strategy is done across the board in increasing awareness about the value of cardiac rehab, disseminating best practices through the change package. We've got a whole objective on building equity in cardiac rehab participation and staffing models for cardiac rehab, an element of innovation and hybrid models, and then finally using surveillance for cardiac rehab uptake. And we do develop and maintain those cardiac rehab surveillance activities. I'll share a tool in just a moment. We also work and support engaged state and local partners like I'm doing with you all today. There has been a health department funding that will be wrapping up in this September. We have a recognition program for hospitals and health systems that includes cardiac rehab as part of the application process. And then there's a wide variety of activities that we help facilitate collaboration with AACPR state affiliates, ACC chapters, QIN-QIOs, payers and other regional partners. So helping to share best practices and facilitate those collaborations across different sectors has been really exciting. We also work in advancing development, validation, and adoption of the new cardiac rehab delivery models, and I'll speak to the think tank in just a moment, and then amplifying key messages about the value of cardiac rehab and strategies to equitably increase participation. So I mentioned the CRC. Our focus again is that 70% target. We convene on a quarterly basis, and we just had our meeting in February, so our next one will be May 16th. And there's a link to join if you care to join this opportunity. It's a great way to connect with folks across the country, get direct access to some of the leading experts across the country in cardiac rehab uptake and policies. So open forum, you all are invited. I mentioned our surveillance activities. So we do have cardiac rehab participation data available on our interactive atlas for heart disease and stroke. Here you see in yellow are the cardiac rehab programs. I'm focused in on your region. We see in dark blue is the participation rate among those eligible. Again, this is Medicare beneficiaries. And we see a wide spectrum of uptake and opportunities for focusing and localizing efforts in different regions. I mentioned our work of the think tank. So we do have a model. We know that the current brick and mortar cardiac rehab program facilities are not sufficient to meet our target of 70%. So we're looking to expand traditional cardiac rehab, but also enhance the hybrid cardiac rehab models. And again, bringing cardiac rehab beyond the centers to patients' home or in the community to help bridge that gap and meet the demand. And as part of that, we had a meeting in October of 2020 called the Cardiac Rehab Think Tank, where we began to discuss how we can standardize the process. So we developed some standardized terminology, which has been published in our paper by Alexis Beatty and colleagues, the Cardiac Rehab Accelerating New Care Models, excuse me. Revisiting those core components of cardiac rehab and what's essential, and this will be a paper coming out later this year. We've had some policy efforts underway, and this is really where ACPR is leading the charge and helping sustain the delivery of virtual cardiac rehab beyond the public health emergency. So currently the Medicare opportunity to get reimbursed for virtual, that's the synchronous audiovisual communication for cardiac rehab, will be ending with the public health emergency in May. We've got some strategies to build equity in cardiac rehab participation. Implementation. So there was a guide published by Stephen Gatayan and colleagues on designing and implementing hybrid models, and then highlighting some research gaps and addressing those gaps. So there's been a new PCORI funded effort across 3 different centers to study the impacts of a hybrid cardiac rehab program that's, again, relatively standardized as far as its design. Lastly, some cardiac rehab resources. We do have a webpage that's available for syndication. If you care to have a cardiac rehab presence on your website, you're welcome to use our content. We've got a communications toolkit with a variety of different public-facing materials. I've mentioned the Cardiac Rehab Collaborative and Facebook, Twitter, and LinkedIn. We're always on social media helping to promote messages on cardiac rehab uptake. So hopefully by now you have a sense of how you can engage in some opportunities or new tools to explore. I do want to show just a couple other opportunities for you all that have just recently become available. One is some new grant funding. This is coming out from our colleagues in the Division for Nutrition, Physical Activity, and Obesity. The Active People Healthy Nation initiative has 3 funding opportunities that are currently open that focus on state physical activity and nutrition programs, high obesity program, and the racial and ethnic approaches to community health. So just helping to amplify those opportunities. I mentioned our hypertension control champions. Well, as we announced those champions, we also launched the 2023 challenge. So this is currently open. It started yesterday and it will go through April 14th. And we still have a couple states that have yet to have a cardiac rehab champion. I'm sorry, a hypertension control champion. Also, they include Maine and Vermont, I believe, are the 2 states in your region. So if you know of a clinician, a health system, or a practice that's achieved 80% or better blood pressure control, we hope that you would help partner with us to get the word out about the opportunity to apply for this recognition. There's also a couple of campaigns underway. Start Small, Live Big is focusing on encouraging adults 55 and older to take small steps to improve their cardiovascular health. And then currently Live to the Beat has been very active for Heart Month and also for Black History Month in empowering Black adults to pursue heart healthy lifestyles. And as part of Live to the Beat, it's a very big initiative. There's a lot happening. There's some promotional content. We've got some great PSAs to put out. You might see it on the news channel. There's been a big blast effort underway. There's some educational resources, and I want to highlight the pulse check is an opportunity for folks to go on the website. They put in some information and they get to see which type of risk factors they might want to address, and it provides some tips and opportunities to help address those risk factors. And then there's also some promotional gifts and activities for optimizing engagement. As part of Live to the Beat, there's also development of a community ambassador network to help bring these messages into the community in partnership with community-based and trusted partners, if you will. So getting those messages out, promoting sweepstakes and opportunities for engagement, and also getting some recognition for those individuals that are helping to serve and amplifying the message. If folks are interested in joining the Ambassadors Network, if you go to the Live to the Beat website and click the About tab, you can see a description about the opportunity to be part of the network, and it will give you some instructions on how to connect. So lastly, hopefully you have some opportunities to engage. Again, please use or share the hypertension control change package and the cardiac rehab change package. They are for your use. We encourage you to join our collaboratives. We've got quite a few of them, and always welcome our QIO, QIN partners, amplifying messages about the hypertension control challenge, especially in Maine and Vermont, and then helping to amplify Live to the Beat messages as well. So hopefully you have something to grab onto. I appreciate your attention, and thank you so much for having me today.
Haley, thank you so much. That was, I mean, I learn something new every time I hear you talk. So I definitely took away some new tidbits, and really, this is a great opportunity to ask Haley any questions you have about Million Hearts, the tools or resources, or their engagement campaign. So I think we had one question in chat from looking back at your slide in terms of I think the state that had the best record for cardiac rehab was Nebraska, and I was wondering if you knew why that is, if they have like more programs maybe, or just more engagement.
It's interesting. I remember I had that question recently. I presented to a group in Michigan, and they had the same question. It was Iowa and Nebraska had some of the highest participation rates, and yes, they have at least one cardiac rehab program per county. And so that was interesting. I haven't figured out why that is. We're seeing different trends across the country. I recently looked at some Medicare Advantage data, and it seems plans in Wisconsin and Minnesota have had the highest participation rates. So we're always interested in insights and exploring why that is, but we don't have the best assessment of what's happening in Nebraska specifically. But I know a lot of part in that region and the northeast corner, the northwest corner of the country, we see a lot more cardiac rehab programs per county. So we're exploring why that is.
Well, that's really helpful to know. Thank you. It's very interesting. So definitely chat in, or you can take yourself off mute to ask Haley a question. We'd love to hear from you. It's a great opportunity to hear from the expert.
I might ask the group, do you see one action you could take from what I presented? I'm seeing a couple of head nods. You can use the thumbs up as well. There are quite a few opportunities for using tools, but also, again, our learning collaboratives have been a really great way to engage and learn best practices from across the country.
Absolutely. Yeah, the collaborative, I've been attending the cardiac rehab collaborative meetings for a while now, and they're excellent. It's a great opportunity to connect and to learn more about what's going on, and opportunities for building awareness about cardiac rehab. And so, actually recently I started attending the climate, change, sessions that you have, looking at how what's happening in climate is affecting cardiovascular health. So it's sort of another initiative that's underway as well. So there's a lot of interesting things happening. Well, we'll let everyone sort of ponder. Go ahead, Donna.
What was the disease rate for Nebraska versus, when we're looking at Nebraska having a high rehab component, is their disease level much less than in the South? So it's like you know, if you have a higher concentration of higher disease in the southern states, like I think I saw Texas being quite high, where Nebraska, maybe there's more, there's a difference in nutrition and environmental, you know, things that would affect, you know, getting outside more versus, and of course, you know, the demographics of the population are different.
Yeah.
And so if you have more Caucasian participants participating, then that would actually bring up the level of participation for that area. And when you compare it to an area in the South where there's fewer people participating of people of color, then you can see, you know, that might play a factor too. So to me, it might be connected to demographics. You know, higher concentration of Caucasian, different environmental things that people get engaged in, dietary differences. I think all of those things might play a part in why Nebraska has a better participation than the other states. That was just my thought.
Yeah, no, thank you. I think all of those are very valid perspectives to explore.
Yeah.
I wonder if there's also a sense of maybe fewer cities in Nebraska, and so people have greater access to the health facilities in those regions.
Yeah, fewer people per provider.
Yeah.
And
Yep.
so when you're living in an area that's really congested and you've got a provider that's overseeing, you know, 10 times the amount that you would in Nebraska, then attention would be more focused in a more rural, isolated area than in a more congested, heavily populated area. And of course, maybe less stress as well.
Yes. Yeah.
You know, because of environmental differences. The heat in the, you know, in the South is pretty bad.
Even the training of cardiologists and whether or not they got told about cardiac rehab, it's not generally part of the criteria for training for cardiology and physicians as well. Again, it's not necessarily all patients that come through the hospital. It could be a person with heart failure or stable angina that's seen in the ambulatory care setting. And if that primary care doc is not well connected to a cardiac rehab program, that referral is most likely not going to happen.
Yeah. Yeah.
Thank you, Donna. That's, you know, really it's a really great segue into our next slide, actually. You know, we're just wanted to kind of circle back on some of the things that Haley brought up related to disparities, you know, sort of like, you know, part of what we need to do here at the QIN-QIO is look at health equity in all of the work that we do. And we know that, as Haley mentioned, you know, there's definitely some disparities when it comes to both hypertension control and related to, you know, cardiac rehab, you know, attendance. So, you know, I just found a couple of other, you know, statistics. And, you know, what I thought was interesting was that people of color are also more likely to have high blood pressure earlier in life. And then, you know, just like Donna was saying, you know, we have a lot of structural inequities, you know, related to the environment. There may be, you know, different levels of access to care. There may be, you know, different, you know, factors in terms of social economic disparities as well. And so, you know, all of that can certainly impact, you know, around with cardiac rehab, you know, there may be, you know, just like we said, you know, depending on where you are, you know, different levels of access to programs and different level of awareness. So next slide, please. So here are some strategies, you know, some of which we've already talked about, you know, really looking at the social determinants of health. So we know that, you know, food insecurity, if you live in a food desert, you know, your housing situation, employment, health insurance can all impact your ability to address your hypertension, you know, may impact your ability to have access to cardiac rehab as well, especially transportation. We know that, you know, some people can't, you know, actually get to a cardiac rehab program, for instance. So really looking at those, you know, asynchronous, hybrid, virtual offerings is really something that you know, the Cardiac Rehab Collaborative has certainly been focused on, as Haley said. Just, keeping in mind to screen for and address those social drivers. And then we really think that the shared decision-making tools are a great way to make sure that it's, collaborative decision-making between provider and patient. That can certainly also help in terms of providing that person-centered care and culturally informed care. Making sure that it's, sort of an educational piece. Everyone has sort of different levels of health literacy. And so actually right now, we're in the midst of a series on the class standards. So that's culturally and linguistically appropriate services. And if you're not familiar with those, if you're interested in learning more and, ways of implementing class in your organization, we, definitely encourage you to attend those. You can find the links for those events on our upcoming events page. And then again, also, circling back to, the barbershops, right? And so it's definitely had a lot of success there in terms of connecting with the community. Those community centers are trusted, and it's a great way to, really meet people where they're at and, help them with their health goals. So we'd love to hear from you in terms of any successes or challenges you're having in terms of advancing health equity for heart health. I think, anytime there's a best practice, we want to make sure we, are aware of it and can spread it. And also, to hear, about maybe some things that aren't going as well as you would like, and, ways that we can maybe support you on that. Next slide, please. And so, in addition to all the great resources at Million Hearts, we did just want to share a few things that we have been building here at the QIN-QIO. So we have put together what we call links portfolios, and links is for local interactive network of knowledge sharers. And this is really for the community-based settings. So, might be like an area agency on aging, or, a community center, senior center, different groups like that, that are really out in front of the community members. And it's a way of educating them on how to measure blood pressure, what hypertension is, and what they can do to help better control it, whether it's lifestyle change or, how to, work with your doctor, and also have a, sort of fact sheet about what you need to know about managing your cholesterol. We know that's all connected. And then on the cardiac rehab side, we put together a sort of a quick guide. It's only about 10 pages or so, and it sort of combines everything that, with that Million Hearts and also Take Heart, cardiac rehab. And, we just sort of pulled everything together so that it's sort of an easy way for everyone to just kind of see what's available, really focusing in on the change packages that Haley mentioned. And then we also pulled together a list of all the cardiac rehab programs that we could find in the New England area, just sort of help you, and your patients, whoever you're working with, sort of find one that's closest to them. And hopefully, these will be some helpful tools for really building awareness and encouraging both referrals to and participation in cardiac rehab. Next slide, please. So here's just a look at what the portfolios look like. So we kind of have a one-pager on suggestions on how to use it. Sort of like what Haley said, putting stuff out in your social media, any way we can get the word out. And, here's an example of the hypertension fact sheet. Next slide, please. So here's some additional resources. We always want to make sure we're screening for those social determinants of health. So we always recommend the Prepare tool, and we have other tools on our resource library. If there's a lot of different ones out there for screening for social determinants of health. And then we have a quick guide on how do you, okay, let's say you found that somebody has all these different unmet needs. The guide for getting started is a great place to go to look up services that are nearby, like using Find Help or the Elder Care Locator and other search tools. So you can help the person that you're working with find something that's close to them, to either, whether it's like, to address food insecurity or transportation and other needs. And then we have a specific guide to screening patients for food insecurity. And we also have one specifically on transportation and social isolation and loneliness, as we know from looking at the Z codes. So Z codes are ICD-10 codes that identify unmet social needs. And the top code in the New England area is, and actually in all of the QIN-QIO, is problems related to living alone. And so we did put together one specifically looking at how do you screen for that and then help someone address their isolation. And then we have going back to the shared decision making, we have these decision worksheets that MGH has, and they have them on variety of different conditions. Are a great tool for getting the conversation started. And we have a whole page just on the health equities and our culturally and linguistically appropriate services resources are on there as well. Okay, next slide, please. So we really hope that you can join us for our upcoming session. Like I said, we'll be sharing the slides and the recording from today, and encourage you, if you're interested in learning more about cardiac rehab, to come to our learning circle on March 15th, and then also to join us again on May 10th. We'll be taking a deeper dive. And you're welcome, of course, to come to whatever session speaks most to you and what you're working on right now and what your focus area might be. And next slide, please. We will be sending out a really quick survey. It's only like 4 or 5 questions. Love to get your feedback. Want to hear from you. What's working. What you would like to see more of. Is really helpful for us as we continue to plan our education sessions. Next slide, please. And here's our website. So check us out if you haven't already. We have a lot on our resource library, and you can find all of our upcoming events on our events page. And, just sort of a last call for any final questions or comments before we wrap up for today. Next slide, please. And if you don't have any questions, I just want to say thank you again to Haley for joining us and sharing everything that's going on at Million Hearts. And thank you for your continued partnership, your commitment to quality improvement. And again, we hope to see you at our upcoming learning circle on March 15th. And Karen, did you have anything else you wanted to add before we wrap up today?
No, thank you. Excuse me. Thank you, Laura, and thank you, Haley, and thank you everyone for joining us today. We've said it quite often. The last few years have definitely been something that we never thought we would go through. And respectively, we needed to focus a lot of attention toward the pandemic, COVID-19, and responding. So now this is just an opportunity, as we kind of talked about, kind of getting back to basics and relooking at chronic disease prevention and management. So we're hoping these tools and resources that we provided today is just a starting point, and we can continue the conversation in our future sessions and really reach out to any one of us on the QIN-QIO staff. We're more than happy to support your QI efforts, provide tools and resources where when we can. In the Million Hearts campaign, they just have excellent resources and tools, and I can't talk enough about the hypertension change package and all the materials that are included in there. So please give it a chance, look at it, go on the website when you have some time, and we look forward to hearing your feedback. So thank you, Laura.
Thank you, everyone. Thanks, Haley.
Thank you.
All right. Well, I hope everyone has a good rest of your day. We'll see you again soon.